Welcome, everyone. I'm Ann Godlasky, president of the National Press Foundation, and I'm so glad you're joining us for this webinar, Making Sense of the Childhood Vaccine Schedule. There's certainly a lot of sense that needs to be made for news audiences across the country, and so I'm very excited to have the panel that we have with us. I'll be introducing them momentarily. But first, I want to thank our sponsor, Vaccinate Your Family, a nonprofit that has promoted vaccine education for more than 30 years. As always, the National Press Foundation is solely responsible for today's content. So to deepen our journalists' understanding of childhood vaccines, as I mentioned, we have a fantastic panel with us. Dr. Paul Offit is director of the Vaccine Education Center at Children's Hospital of Philadelphia, CHOP, and a voting member of the FDA's Vaccine Advisory Committee. Dr. Mona Amin is a pediatrician and founder of Peds Doc Talk, which reaches more than 1.5 million people through her podcast, YouTube, Instagram, and TikTok. Dr. Alok Patel's experience includes serving as a pediatric hospitalist at Lucile Packard Children's Hospital, a clinical associate professor of pediatrics at Stanford Medicine, and as a medical on-camera expert for PBS, CNN, and Good Morning America, to name a few. And my friend Lauren Gardner is a political reporter specializing in the FDA and pharmaceutical policy coverage. So a really great panel with us here today. Thank you all for being here. So we cannot get started in this conversation, I think, without first talking about what happened on the Advisory Committee on Immunization Practices last week and their decision to recommend delaying the hepatitis B vaccine. Dr. Offit, as a former member of ACIP, I wonder if you could explain this decision, how it was made, and what you expect the impact to be.
Sure. So let me try and sort of give a broader overview. So in 1981, the hepatitis B vaccine was licensed. In 1982, it was recommended for all babies whose mothers were found to be hepatitis B surface antigen positive in the first trimester, or said another way, infected with hepatitis B virus. That didn't make much of a dent on the incidence of hepatitis B infections in children less than 10. Then in 1988, they extended the recommendation to include not only children whose mothers were infected in the first trimester, but whose mothers were at risk of being infected, like Southeast Asian immigrants, Alaskan natives, etc. That also didn't make much of a difference. So in 1991, now 9 years in to having that vaccine, they made the recommendation for a universal birth dose. And with that, we basically eliminated hepatitis B infections in children less than 10. There was more than a 99% decrease. Now, what the ACIP wants to do is they want to go back to where we were before 1991 and just say this, that they recommend the vaccine for all babies whose mothers are hepatitis B surface antigen positive in the first trimester or whose status is unknown. But that if the mother is known to be hepatitis B surface antigen negative, then she can reasonably delay that vaccine for her baby until 2 months of age, with shared clinical decision making. But it can't be before 2 months of age. It has to be 2 months of age or greater, with so-called shared clinical decision making. And I think there were a few reasons that the universal birth dose in 1991 worked. One is that, first of all, the hepatitis B surface antigen screening test in the first trimester is not perfect. There's about a 5% false negative rate, or said another way, falsely reassuring rate, where you think you don't have hepatitis B infection, but you do. Secondly, you can acquire that virus in the second or third trimester. But most importantly, half of the children who were infected in 1991, and there was about at least 16,000 or so children that were infected, half of them got infected by relatively casual contact with someone who had chronic hepatitis B infection, usually in their family or in their extended family or friends, because this is not AIDS. I mean, if you live in the home of someone with AIDS, with HIV, you're not going to get it, assuming you're not, having sex with them or sharing needles with them. That's not hepatitis B. So I think when people say you should feel comfortable that you tested the mother and she's negative, you should also test family members and members of the extended family, because it can be transmitted relatively casually. What worries me in all this is you've now made a layered recommendation, a nuanced recommendation, and with that, there's confusion. And I think that was the goal. I think the goal was to confuse. I have little doubt that there will not be children who suffer this. We already are hearing about mothers who are choosing not to get this vaccine, even mothers who are hepatitis B surface antigen positive, because we sent the message, I think, that this vaccine was in some way unsafe. That by delaying it till 2 months of age, you made it safer, which isn't true. It's safe at birth as it is at 2 months of age. And certainly that was a lot of the discussion at RFK Jr.'s ACIP about safety issues, that it wasn't safe. And I really regret that this has happened because I think this is a major step back for children and for public health.
Thank you, Dr. Offit. Dr. Mona, as a clinician and a content creator, you hear from parents directly quite a bit. Are you hearing that kind of confusion, as Dr. Offit mentioned, since the decision a week ago? What else are you hearing from parents?
That is exactly perfectly what we were seeing and what I'm hearing. And that's coming from friends who are having babies. I run into them at the park. That's from social media. And that's also from patients in the office. I also used to round in the newborn nursery, and now I do not. But obviously, as an outpatient pediatrician, I'm very in touch with all the people who still practice. And even before this recommendation, there was a lot of vaccine refusal and refusal for the eyes and thighs, which are Hep B, vitamin K, erythromycin ointment. And, of all of those things, all of our clinicians that do round are constantly talking about the importance of all three. Some families are like, I'm not getting it. Absolutely not. And we convince them to at least get the vitamin K and then come to the offices to get the Hep B. One of the biggest concerns that we're having right now is the population that's going to be most affected is the population that public health policies tend to serve the most. And that is the underserved, lower socioeconomic status families who have poor follow-up. They may not get to their doctor. They may not be able to come back. And one of the other recommendations from the ACIP meeting was to check titers after you get your first dose at 2 months, for example. That policy is already going to inundate an already overburdened healthcare system that is struggling just to see the patients we have. And now you're asking us to check titers when titers weren't really ever recommended in a healthy newborn post Hep B. And so a lot of the recommendations come with a lack of understanding of new data, like Dr. Offit had said, right? There's nothing new about this. It creates a lot of hesitation. It creates a lot of, well, is this even safe? Because now there's nuance. Why is there nuance? I should just get this. And then it also is going to, I believe, overburden a healthcare system that has already been struggling post-pandemic, with clinicians leaving the workforce, with a lot of wait times for patients, and just a lot of now conversations about, let me explain why I want you to get the Hep B, whether it's at birth, which is what we still are recommending, or whether it's you're coming at the 2-week visit or the 2-month visit. So I think this is going to have a huge trickle effect, not only for the confusion amongst parents, but also for how healthcare providers are going to be able to practice medicine, given the fact that we're now going to have these longer conversations, which sadly, in this healthcare model, we don't always have time for in a clinic setting, because we have 10, 15-minute visits, and parents deserve it. But the system isn't lined up to be able to have all these nuanced conversations, like Dr. Offit said.
Mm-hmm. Parents, of course, have always been a very engaged news audience. And as you all know, journalists are our primary audience on this webinar today. Parents now, of course, are getting information from so many different sources, much of it conflicting. And some of it, as we know, incorrect. Dr. Patel, you have a very strong online presence. I wonder if you could talk to us a little bit about your approach to dealing with misinformation when you encounter it in this area.
Loaded question. I wish we all had 5 hours to gather in person to talk about this. I want to give a massive shout out to all of you for even bringing journalists to the table, because I think this is very important. The first step that I personally take, and I'm sure that my colleagues, Dr. Offit and Dr. Amin, agree with this as well, is I try to listen first and figure out where exactly the misinformation is stemming from. One big disservice I think that we have done, at least according to the data over the past 10, 15 years, is labeling vaccine hesitant parents with anti-vaccine. There is a scientific process of being skeptical, about asking questions. And if parents do that, I try not to put them into this bucket of, quote, anti-vaccine. They may have a specific question about the timing of one vaccine or an ingredient, but not necessarily against the concept of giving their children vaccines, which there are certain parents who do fall in that category. So the first thing that we have to do is listen. And listen may not necessarily happen on the one-on-one level, but we can do that on a population basis as well and figure out what exactly is the hesitation about a specific shot or vaccine, what's actually happening. And we can look at surveys that are out there right now. We can look at think tanks such as Frameworks and with the American Academy of Pediatrics and figure out why exactly are certain people in this specific community or within this cultural group not going and getting the MMR vaccine. What is it about vitamin K? And I'll use that as a specific example, even though it's not technically a vaccine, but I've had parents come to me and say, hey, I'm game for hepatitis B, and I'm okay with the erythromycin ointment and all the vaccines, but I've heard that vitamin K may cause leukemia, which is absolutely not true at all for that matter. But I think that conversation, first and foremost, is so incredibly important to then figure out how we can have targeted messages as science communicators, as advocates, as journalists, and so forth. And then we also have to kind of look to see what actually works when people are spreading misinformation. And one of it is not only emotions, but also the anecdote. And the anecdote, people tend to look at this one little cherry-picked story and use that to kind of cast this wide net about a belief. On these ACIP calls, on these webinars, we'll hear these clear examples of misinformation, such as someone calling in and falsely linking a vaccine such as hepatitis B to autism. And all of a sudden, this one emotional anecdote has taken over the airwaves, and it's what's getting shared on social media. And so we then should go to social media and look to see what are people responding to. And so to kind of summarize what I'm rambling about right now, I think the first thing is to first not loop everyone who's vaccine hesitant as anti-vaccine, but then to also really take a step back and say, okay, what are we actually hearing when it comes to misinformation? How do I address that specific point? And can I make a targeted message related to that? Can I explain to people that aluminum is one of the most common elements in our atmosphere, the most common heavy metal in our atmosphere, and it's in our food supply, our soil, and breast milk, and it exists in vaccines in an extremely microscopic amount in comparison. Babies ingest it every day. Can I tell parents who are worried about formaldehyde that it is a byproduct of DNA metabolism and it's floating around in your body? And can I show parents these specific points to address what they're seeing? And can I be there first so that these pseudoscience quacks don't get to fear and confuse parents before we do?
Mm-hmm. Thank you. I'd like to touch on something that Dr. Patel said and maybe address it to you, Lauren. As journalists, of course, we're always told to tell human stories, but as we know, personal experiences and the statistical truths don't always line up. So how do you handle this in your storytelling?
Yeah, that's a great question and is definitely something I've grappled with, particularly since the pandemic, when you really started hearing even more of this kind of hesitancy expressed by people, whether they're, anti-vaccine activists or just regular people on social media sharing anecdotes of what they've experienced in their personal lives. I try to, especially given Politico, like we're very focused on politics and policy. So I tend not to get into the specifics too much of those sorts of things, but I do try when it's warranted to kind of flick at this, that there's like a broader, push by the public particularly on social media to invoke these sort of anecdotes that, don't necessarily have data to back them up, but are being cited by people as reasons to be more skeptical of vaccines. Just using it as a way to just, elucidate to people, this isn't just coming out of thin air. There is a reason why this stuff is gaining traction. And a lot of it is because it kind of catches fire on social media.
Yeah. Well, I know obviously we started by talking about Hep B, of course, with the news last week, but I would like to take a step back so that journalists can kind of help the public understand the process behind all of this. And Dr. Offit, you did get into it a bit before, But I wonder if you could talk about who's making these decisions and what evidence they're using.
You're saying it at RFK Jr.'s ACIP, that group, you mean?
The childhood vaccine schedule in general. So if a parent is like, who's actually deciding this? Who decides when these shots need to happen?
Right. So typically, before Robert F. Kennedy Jr. became Secretary of Health and Human Services and fired 17 people at the ACIP, claiming that they were all in the pocket of the pharmaceutical industry, and then hired initially 7 people who, like him, had an anti-vaccine, anti-science bias. The ACIP did. The ACIP set what was the childhood and adult immunization schedule. Unfortunately, excuse me, I'm fighting a cold because I visited with my grandchildren about a week ago and still suffering that. But
I understand.
But we can't trust the ACIP anymore. We can't trust the CDC anymore. So the most recent, if you take aside this December 5th discussion about hepatitis B, I mean, the September discussion, they talked about the COVID vaccine. And so what they said was that anybody over 6 months of age could get the COVID vaccine with shared clinical decision making, but they didn't make a recommendation for high risk groups. I mean, the goal of the COVID vaccine is to keep you out of the hospital, keep you out of the ICU, keep you out of the morgue. So who's getting hospitalized? Who's dying? It's primarily people who are in the high risk groups, like people over 75, people who are immune compromised, people who have chronic medical conditions, women who are pregnant are the highest risk groups. And there's still hundreds of thousands of people hospitalized with COVID and tens of thousands who die. Is it a disease worth preventing it? Sure it is. So we look to the ACIP for that kind of guidance and can't do that anymore. So what's happened is other groups have stood up. So in the case of childhood vaccines, the American Academy of Pediatrics has stood up and have their immunization schedule and have worked with insurance companies to make sure that insurers will cover those based on best medical practices, based on best information. So so we're in a flux period where what we normally look to for advice, now you can't look to advice. So you're finding these professionals, either medical or scientific societies stand up, states are standing up and creating their own expert advisory panels. So we're in this kind of middle ground where it's all kind of settling out.
And I'm going to come over to Dr. Patel and Dr. Amin in a second, but Lauren, I'd like you to react to what Dr. Offit just said. How is all of this impacting how you think about sourcing?
Yeah, it's a lot. It seems like a fire hose of information is kind of being directed at us frankly, every single day. When it comes to things like what happened last week with ACIP, I have a history of covering those committee meetings going back to the pandemic, so I'm pretty well versed in how they traditionally went compared to how they go now. So if I feel like I need to kind of widen the bench of sources that I'm going to figure out what the heck is going on, I might go back to former members who specialize in whether it's, a specific disease area, or, they're just generally a pediatrician or they're a vaccinologist. I might turn to those sorts of folks. I also have a roster of lawyers that I go to who specialize in federal and state vaccine laws, as well as whether it's FDA or CDC agency processes and that sort of thing. So I try to keep it focused on people that have like a long-standing track record on the science and on like kind of the legality of a lot of these things. And I've also tried to make it a point, particularly over this last year, to diversify who I'm talking to. I know Dr. Offit very well, but I've been looking for some other folks too who are kind of people like, Dr. Amin. We haven't talked, but I follow her on social media. Folks who are, they're clinicians, they're public health experts, but they're also really trying to get into the communication space, because more and more of those people, I think, are really, especially in the last year, have come to understand that there is a communications gap with respect to the broader public, that the message is just not translating for people. And while I might be a different side of the same coin on the communication side. It's something I have to think about too, because while I might be writing for a more, specialized inside the Beltway audience, when I do have stories that go, as we say, in front of the paywall, I still want them to be accessible to people. And I want to also figure out ways to talk to certain people and write things in a way that make sense to the average American who's just kind of, same as me, also just overrun with information.
Right. So but before I continue, I do want to remind the folks who are tuning in that you are welcome to ask questions. We will direct them to any of the folks on the panel. Feel free to submit your questions either via the chat or via the Q&A function along the bottom. So Dr. Patel, I have to go to you after what Lauren just said. You are an expert, I would say, in not only a medical expert, but in terms of trying to get people engaged with this content. What do you wish more journalists did to really try to get people to tune in, get people to keep reading, get people to pay attention to the factual information?
I appreciate the kind words. I would not call myself an expert. I am merely someone who is taking it all in and learning as we go. But I talk to producers, journalists, or people working in the news network, the digital network space, almost every single day. And I do see a clear difference between the producers who realize that we need to make engaging, entertaining television, and the ones who realize that, but also say, but it has to be evidence-based, it's got to be legit. We have to make sure that we have primary sources for our graphics, and that we are interviewing people who not only might be charismatic or might provide great answers in print, but also who someone can go and look up and say, this individual is actually credible, and we're standing by the evidence. And I think there's a really important way to do that. And I really respect the journalists who are also going and looking and saying, what are the comments that are out there right now that are catching traction, that are being spread on social media, that are memes that are being shared millions and millions of times, that are reaching people? And is there any evidence behind that? And one very, very important nuance I've come to really respect journalists who are looking at this is saying, is this message worth amplifying, or is it dangerous? If it's a meme that is about vaccines or about public health and there's no traction at all, we should not put this on television. We should not put this in print and inadvertently raise awareness about it, if that makes sense. And this is something, I'm not biased when I'm speaking so proudly of ABC News, but this is something that we have a conversation with all the time. If we do go and do a debunking segment, so to speak, is it worth even amplifying this? If it is a meme that's been shared millions of times about, quote, how many vaccines children now get today versus 1960, I think that's an important conversation, because a journalist can now go and look and say, well, hey, science has evolved and we now protect a lot more children than we did back in the day. So this fear is actually unwarranted, and we should actually celebrate how much we've accomplished, as opposed to saying, oh, this is a one-off segment that we don't need to really look at all. But I guess, and what I'm trying to say here is, the journalists and producers who are looking not only for credibility, for a primary source, who are vetting their resources or vetting their experts, phenomenal job. And also, to add on to that, the ones who actually look to see if this message is actually influencing behavior versus if it's just something that might be sexy for television, that is clutch.
A question for all of you is, are there resources online, whether that's, databases, other places with kind of primary examples that you would recommend that journalists look at, that you would recommend, or even the public, that you would recommend they refer to kind of continuously? And if you don't have one that sticks out, that's fine. I'm just curious if we can kind of build some resources for folks.
Yeah, I think one of the ones I've discovered over the last year is Partnership to Fight Infectious Disease, so PFID. I really like them. Obviously, they just present evidence-based information. They talk about what's happening state by state also, because a lot of things have changed. Dr. Offit was mentioning about the coalitions in the West Coast and the Northeast. I'm in Florida. The politicization of all of it has become very obvious. So they kind of show what's happening in terms of mandates and recommendations. I also like immunize.org, Vaccinate Your Family, AAP. CDC used to be on that list, but dropped off very quickly, sadly, which is a huge source of frustration, just because we should be able to rely on them for evidence-based guidance. But those would be my four: PFID, immunize.org, Vaccinate Your Family, and AAP at this point. And I'm sure there's others.
I would add Vaccine Education Center at Children's Hospital, Philadelphia.
Yes.
Shamelessly, I thought I would do that.
I was actually going to say that if in case it was awkward for Dr. Offit to promote it, because Vaccine Education Center, I will just plug that again. I pitched that a lot to outlets, because the information is great, but also the nuance in addressing certain specific questions, such as why is this the vaccine schedule? What are these ingredients? And actually being able to break things down into the specific questions parents are asking. Very important. I also would request that people look at global sites as well, whether it is the WHO or Gavi, for example, to not necessarily have to quote statistics from other countries, but to kind of get a global sense of what's happening. I think when we have these conversations about vaccines, we tend to think very domestically, because that's what our audience is doing. But we will see places like ACIP cherry pick and look at, well, hey, Denmark is doing this, Japan does this, but they ignore 116 or so other countries that do have a universal birth dose recommendation of hepatitis B. And they forget the fact that we're all interconnected in the world, but vaccine policy has to exist with what the actual health infrastructure looks like.
Thank you. We do have, I'm sorry, Lauren, please, yes, go.
You're okay. I agree with all of those sources. I was just going to say, from the vaccine safety standpoint, in terms of when you're trying to kind of, gut check what people are saying in whether it's these kinds of meetings or elsewhere on social media. To Dr. Patel's point, I think it's GVDN, Global Vaccine Data Network. They're a broader consortium that looks at issues. And Johns Hopkins has a vaccine safety institute. I forget the exact name, but it's pretty findable.
I think Dr. Amin has a podcast also that journalists can refer to. Just saying.
I have a lot of resources. I mean, obviously, Dr. Offit has to come on the show because it's very important that we get this information, but I source anyone in the evidence-based space. We also talk nuance. A lot of my conversations on my podcast talk about benefit over risk language versus safe. And I think that's, you talked about how we can pitch things, wordage. What I've found, has really helped a lot of my families actually end up getting vaccines is, rather than saying, oh, this is 100% safe, saying, this is a situation where the benefits greatly outweigh risk, and this is why I'm recommending it. And going through that language with them, because I don't dumb it down for my population. I do think we have to understand that a lot of the population has a 6th grade reading level, so you can't use a lot of medical lingo, but I explain it to them, minimum 6th grade reading level of hey, here's why we do this. If you don't understand why this is that's okay. Here's what I'm here for. But that has really helped a lot in sort of that, adding that nuance, even if I may have a clickbaity headline. I understand in journalism why you all have to do the clickbaity headline, because you're trying to get people in. But once they're in, if you're using a clickbaity headline, bring that nuance, bring that really compassionate conversation, so that people know that, okay, I'm actually getting something useful, even though the clickbait drew me in. And I hate having to do that for my podcast, but it's how I get a lot of listens, right? The title will be some clickbaity sort of, what is this about? And then I'm doing my evidence-based spiel. And I think we need a lot more voices doing that, because the other side is way more loud on the non-mainstream media. And I think we know that, right? The Joe Rogan podcast, there's a lot of some pediatricians climbing up the pseudoscience ladder very quickly, seeing an opportunity. And so I'm worried about where that's going, because those voices are much louder and there's a lot more money for them. And that's why they keep doing it. But we need to drown them out, like we've discussed, with elevating voices that are giving that sort of compassionate things and doing things like this. And, I think it's going to be really helpful.
I'm going to stay with you. You've already answered some of this, but there is a question directly for you in the Q&A. An attendee asks, what you've seen the most success in communicating information on TikTok, specifically to that platform? What do you find works best?
I think every content creator is going to be different. I have just found that people love my reaction videos. So this is going to be like a stitch where I take a video or take a post and I say, let's discuss all of it, like why this is true or why it just lacks nuance. And I explain that because some of the stuff can be true, but it's lacking the context because those people just spread oh, this kid got blood clots from the COVID vaccine. But do you also know that the COVID vaccine or the COVID virus itself can give blood clots? So when we're comparing the two, let's discuss this. So I found that really helps. I, again, hate that I have to get people in the door to my video with a more oh, Dr. Mona's reacting to something, but it's short attention span geared, right? We have to understand that, especially on TikTok, you got to hook them fast. And that's either going to be something that's, wow, what's going on? Or something like, you need to hear this and this is why it's false. And that includes Instagram too. So the attention span of people has gotten worse because of TikTok, because of social media, because of the popularity of short form video. So in the first paragraph of a article, in the first 5 seconds of a video, you need to make it clear, like, here's what we're discussing and this is false. And sometimes I'll be a little bit of an actress and be like, this is bullshit or this is this. And I do it because I'm playing the game because I know they're all doing the same thing, and I don't like it sometimes, but it's what needs to happen so that I can get the million of views. One of my videos about some anti-vaccine sentiment got like over 25 million views now. And it's awesome. It's one of my most watched videos. And I'm so grateful because people are sharing it like, yes, this is the good information we need. And it started out a little bit like, is this for real? Like, because you have to kind of see how the users are using the platform.
I appreciate you acknowledging all of the balancing that has to happen. Dr. Offit, another attendee asks, as health professionals, how do you manage the shift away from kind of trusting the experts?
Well, I think we should still trust experts. That's clear, right? Well, I know when RFK Jr. says we shouldn't trust experts, I think that's bad advice. And you only have to look at that last ACIP meeting to watch that. I mean, that was one previous ACIP member said, that was the dumbest discussion I have ever seen about hepatitis B. It was really horribly uninformed. And I think so how do we gain trust again? How do we gain trust? If I could answer that question, I would be really happy because it's the question I think that everybody asks and I don't know the answer. We certainly have lost trust. It's absolutely true we lost trust. And I think in the first 2 years of the pandemic, especially, we lost trust. I think we lost trust in the first year of the pandemic because we didn't have anything. We didn't have antivirals till October. We didn't have monoclonals till November. We didn't have vaccines till December of 2020 for a virus that was spread asymptomatically that was killing people. So what did we do? I mean, we just had to limit human-to-human contact, meaning shutter schools, close businesses, restrict travel, mask, isolate, quarantine, test. And I think that was seen as massive government overreach. And it was done in kind of a top-down way. It was. I think it was done in somewhat of a dictatorial way. I don't think we involved the educational community. It didn't involve the business community in trying to help make that decision a little easier. And I think we did close businesses and schools for too long. Then in the second year, when you had a vaccine in 2021, you couldn't really go anywhere without your vaccine card. If at bar, restaurant, sporting event, wedding, place of worship, whatever, and you may be fired from your job. And I think that too was seen as massive overreach. I'll give you a perfect example, actually. There was a meeting in February of 2022 behind closed doors with Dr. Fauci and Dr. Walensky. So Fauci head from NIAID and Walensky, who was head of CDC, and Vivek Murthy, who was the U.S. Surgeon General, and Francis Collins, who then was head of NIH, to discuss whether or not natural infection should count as a vaccine. And then they brought in some sort of virology, immunology types, such as myself, to try and weigh in on that. So I thought, yes, I thought it should count as a vaccine. If anything, you could argue you're making an immune response to all 4 viral proteins, not just one. And that should have been a meeting that should have happened in front of the public. It should have, so that everybody could see, the journalists could see, they could ask questions. And I think a lot of that stuff was done a little bit behind closed doors, and that's the way it felt. So I think we did lose some trust. How do you regain that? I do think we ask a lot of parents in this country. We ask them to give, vaccines prevent 14 different diseases in the first few years of life, which can mean as many as 5 shots at one time. It can mean as many as 25 shots during that period of time to prevent diseases most people don't see, using biological fluids most people don't understand. I think what Dr. Patel said was right. I'm surprised anybody really isn't somewhat skeptical about vaccines, that everybody should be. So you have to respect that. And I just think we have to continue to try and explain ourselves, why we're doing what we're doing, why it's so important that we're doing, why we care, why we really care about getting this right. And that's going to take a while, I think.
Well, I don't think you'll get any arguments about transparency from journalists. But that leads me perfectly, actually, to one of the attendees' questions. Wendy Wolfson, and I'm going to address this to the other two doctors on our panel. She asks if you could address the childhood vaccine schedule, and mentions that she's had highly educated parents tell her that they want to space out vaccines so as to not overwhelm their kids. How do you address that, in a clinical setting, as an example?
You want me to go, Dr. Patel? Yeah. I mean, obviously this is my bread and butter because I'm outpatient general peds. And I think the first step is, why do they want to space it out? What is the concern? Like we talked about with Dr. Patel, is that I don't need to open up a whole can of worms of like things that's not on their mind unless they're asking me it, right? I don't want to seed things that aren't needed to be seeded. So most of the answer to that is that I just feel like it's too much. I'm not anti-vaccine. I just want to get them on my own schedule. And for me, I offer a lot of personal opinions, personal anecdotes. I say, look, I think we're both on the same page here. I think we both care for our children and want the best for our children. And I think we can agree on that. And usually they're like, absolutely. And I tell them, this is why we recommend the schedule, that there's no concern with the schedule as it stands. We've been giving this for many decades, and I have been practicing for over a decade, so I can say that. And then I also say, I have 2 small children. I have given them on schedule, and why I gave it to them on schedule. And what I see in clinic, I see this every time we give vaccines. You're going to come back. We're going to talk about them. And how did your child do? At the most, we'll commonly see the, fever, redness, all that stuff at the first 24 hours. Very rarely can we see X, Y, and Z. I do have a vaccine guide that's like 85 pages long that I offer my families if they want it. It's free, if they want to get into the nitty gritty. And then the most important thing is just having that open communication. Most of the times, because I didn't dismiss them as an anti-vaxxer, that they're just not going to do it, it opens the door for, hey, this person actually is listening to me and wants to make a plan. Most of my families will get it on schedule, and I'm grateful. And I say, hey, thank you so much. Thanks for having this important conversation with me. This is going to be a really great decision. And some of them want one at a time. And I don't get upset. I don't slam my paper down. I know some clinicians who do that because it's not the way that they want it. And, if we're going to regain trust and if we're going to get them in the door, we have to be more of a team effort for the hesitant people. Because what's happened there is then I will say, what feels comfortable for you? Because for me, I'm happy getting the 2 injections and syrup at the same time. Dr. Mona, I think I'd like to do 1 and then come back in a week. Awesome. And I'm like, I want you to know that you can come back tomorrow because there's no spacing between these 2. So if you want to come back tomorrow, but I really need you to come back the following week. These are families that have good follow-up. I know they're coming. I see it in their chart. And then by the 4-month visit, they're all caught up. Is it what I want? No. Did they get vaccinated? Yeah, right? It's better than having someone say, well, this doctor didn't listen to me, I'm out the door, and going to Dr. Sear's schedule or going to some other place that's going to feed that don't get any of these things. And so I found that by meeting the compassion, answering their questions, giving the fact that, hey, I understand the concern. And I want you to know that when we study these and when we give them, and as a clinician, I'm always watching what's being done with my patients, right? If I ever once saw that there was a trend of something happening with my patients, I would sound the alarm and we would pull that vaccine. Like, meaning our practice would bring that up because I work for a very large practice. And so they believe that, they trust it, and it's just really eye-to-eye conversation and meeting them where their heart lands. And that's sometimes what we need is we need the heart-to-heart versus the logic. Just like a child, right? When they're scared and when they're frustrated and nervous, just seeing them for that and then giving them the logic after of like, hey, I get it. I'm a mom too. I want the best, but here's why, and then here's what we're going to do. And so many of the families who have said, I only want to do 1 at a time, end up coming back at the 4-month and they're like, hey, they did well, I'll just do them all together. And that is awesome, right? Because I gave them some space, I showed them that it's going to be okay, and then they realized that, yeah, it was okay. And I don't discount that, is there a rare side effect? Sure, they know that, and we talk about that if they have questions, but they know that, okay, this makes sense for me, and I love that. And I get a lot of appreciation from my families for that, because they have seen other clinicians who, and I used to be that clinician who's like, you got to do it this way. Okay, well, you're an anti-vaxxer, you're not listening. And then they dismiss or they leave. And that is not what is getting people to actually vaccinate. So I'm happy that I've shifted my ways in the last 10 years too, because I think it's leading to more transparency and trust again.
Can I add? I totally agree with everything Dr. Amin said about kind of having that conversation. It's interesting because this alternate vaccine schedule, which showed up, it was kind of made up about 10 or so years ago. The analogy I would use to families is like, it's like telling a child there's no monster under your bed, but here's a bat just in case there is.
Yeah.
You're adding fear and doubt to something that's been kind of set in scientific stone. We did a segment regarding the childhood immunization vaccine a few years ago with ABC News, and it was kind of rapid fire in trying to address specific concerns people have about the vaccine schedule. And we found that by having these really clear, pointed explanations, such as the vaccine schedule to some form has existed since the 30s, people all of a sudden are like, wait a minute, so this isn't something that was made up over the last few years? Absolutely not. You're just now paying attention to it because there's amplification about it. We also would like to remind people that these doses are set in a certain way based on severity, timing of exposure, and when children are able to actually take in this vaccine and form a good immune defense, and then when there's tragically an example of that going awry, we be sure to add those anecdotes. Sorry, grammar's not my thing right now. We add those anecdotes to stories as well. We're seeing outbreaks of pertussis, for example, from parents who delay a vaccine and all of a sudden coverage isn't optimal. Sadly, this year we saw a measles death in a child who wasn't protected because they were too young for the vaccine, because ACIP was like, hey, this vaccine can safely be given a little bit later. So by showing how the actual schedule works to protect everyone on a population level, I think we've actually made a little bit of headway with certain groups who question it. And the last one I'll add, because this comes up all the time, is this concept of this many vaccines at this time with all the colors on the childhood vaccine schedule. This is going to overwhelm a child's immune system. And we've even heard that piece of misinformation echoed by our president. We remind parents, if you actually look at these responses to your immune system, so what is going to come in and trigger an immune response to your child, these adjuvants, the amount that you're going to get from vaccines is nothing compared to what a child runs into every single day, from licking toys and eating dirt and existing on planet Earth. Your child's immune system can absolutely handle it. So I think the conversation extremely important, and then going through these specific questions people have about the vaccine schedule is also extremely important.
Yeah, can I just add one thing quickly? I think I agree with everything that was just said. My wife is in private practice pediatrics, so I've in a relatively sort of upper middle class community. So I've watched her go through all this, and she initially tried, just do the best you can. If you can get one vaccine into them today, great. Just do the best you can, and knowing that this meant that you were at least for a period, increasing the period of time during which children were susceptible to these diseases because you're delaying them at some level without benefit. It's a well-tested, well-hewn schedule. You can't put something on the schedule without doing concomitant use studies showing your vaccine doesn't interfere with the safety or immunogenicity profile of existing vaccines versus vice versa. You see our dog in the background there. And so she changed. What happened to my wife is she just sort of changed, and she basically said, let me love your child. Don't put me in a position where you're asking me to send this child out of this room when I know that this child could potentially suffer measles or suffer pneumococcus or suffer, flu or whatever. I can't do it. I can't emotionally do that. And it was really hard for her. And she became much more able to convert people to getting vaccines by doing that. But it's really hard to do that, I think. And I watched her anguish in all that. I'm curious to hear your guys' comments. I mean, I'm not in private practice pediatrics, but what your thoughts are, Mona, and others.
Yeah. No, I think it's such an interesting thing, because I think I went the other way of being more like, hey, this is what's important. And then I found that I was able to hit more people the other way. And like I said, a lot of them end up getting it on the schedule because of that whole, because it's almost like, because I was okay with it, then they're like, oh, so she's okay with it, but she also says that this is what she would do. So let me just do what she says. So it's almost like a mind game of like, hey, yeah, what are you thinking? Why won't we do this? Why don't we do this together? And so it also just depends, like you mentioned, on the population type. And I want to be clear, because I work in a very socially and economically diverse community. And I only am having those like a little more nuanced conversations with the families that I know are going to come back. And I know you're like, how do you know? I know. And so if it's a family that's like, like they're already late for their 3 children, like transportation issues, I'm concerned that they're not going to return. And then I'm getting a little more concerned there that, this is something that I have to be a little more firm here. But it definitely is an art of like figuring that out and playing these games. But I think in the next 10 years, I may change again, and especially let's say in the next 3 years with this entire, there is true frustration with the ACIP and all of this happening that I'm not going to hopefully let that show up in my practice, but hey, I want you to know that this is what we would do as a practice. And all those policies from politics are already hitting our practice in various policies and threats to remove funding. I mean, we're getting it all. I mean, it's pretty horrible what's happening in Florida right now with the vaccines and stuff. And it's the worst case scenario that I could have imagined. But yes, it's something that I think might change as I practice more and get more frustrated with the status of how things are going.
It's interesting. What RFK Jr. will say when he was a boy, he only got 2 vaccines, and now we get all these vaccines. And I'm roughly his age, so I too, as a boy, got 2 vaccines, and it was smallpox vaccine and the DTP vaccine. So smallpox is the largest of mammalian viruses. That's 200 separate immunological components. The whole cell pertussis vaccine was the greatest immunological challenge ever. It's the only time we gave a whole killed bacterial vaccine. 3,000 immunological components. Together, they are much more than we give children today. So obviously, people look at the number of shots, but it's really what's in the shots that matter.
Yeah.
So.
It's interesting how the people, Dr. Offit, who talk about the schedule in the 60s also never pay attention to what childhood mortality looked like,
right?
60, 70 years ago, and ignore that data and kind of glance over that just to look at the childhood vaccine schedule. So we do like to also remind people who will say something like, well, hey, back in the day, we did not get this many vaccines. We also did not have autism, which again, we just had different screening tools, but also to remind people to look at childhood mortality in the 1900s. Look to see what children were dying from in the 1900s and in other countries that don't have vaccine access, and then let's play a comparison.
I'm going to go back to the participants' questions a second and bring Lauren in here. Because speaking of things like, vaccine ingredients and those sorts of things that, people might not be able to recite off the tops of their heads. Chris Bolt asks, do you think there's value in doing stories that are explainers, maybe to emphasize the value of experts and science and basic facts? And if so, any thoughts on how to make them compelling?
Is that directed at me?
Yes.
Yeah, absolutely. We've definitely done that at Politico on a lot of these issues that ACIP has either telegraphed that they're going to look at or has just kind of outright said. So, for example, aluminum and hepatitis B, we added an explainer that ran. I think it was just on the subscription side last week, but we kind of outlined, here's where skeptics are coming from. Here are the arguments that have been put forward by groups like Children's Health Defense, which now Secretary Kennedy used to run. And then, here's the like public health argument. Here's the data. Here's, why the universal dose was originally put into place in the 90s. And here's why risk-based recommendations didn't work in the US. I definitely think there's certainly value in terms of how to make it like punch through. That's going to depend on your medium, right? TV is very different from print/online, and I don't deign to know what makes a good TV segment. But just I think as a journalist, and especially on these issues, I am a parent. So I try to come at it I try to look at things through that lens too. I have a toddler. It's not that hard for me to look back and remember, oh gosh, like this, X period of time in her life was so crazy and stressful because of, X, Y, and Z, usually developmental things that I wasn't sure if things were going right or what have you. So like sometimes I have to step back a little bit and put on my parent hat and think, okay, what would I have liked to what would have gotten through to me? What was I looking for when I had a question about, maybe a different medical issue back then? And usually, it's translatable enough to, in this instance, vaccines, where I can take that and apply it to, what's on my plate at a given moment for my current job, if that makes sense.
I love the relatability. I love the relatability.
Dr. Mona, you just mentioned Florida, and we have another question from a participant. How concerned are you about vaccine access driven by the political landscape moving forward? Mentioning Southwest Florida specifically.
So my biggest concern, parents are asking, like, let's use the Hep B example, right? Like, they're like, well, if I want it, I can still get it. I'm like, yes, as of now, in hospitals, you can get it if you want it, even if you're Hep B negative, okay? And that's awesome. But my concern is that we think about, I'm going to use the example of the COVID vaccine. There hasn't been a big uptake of the COVID vaccine for children. And because of that, it's very hard to get the COVID vaccine because it costs money to store, train the staff to administer it. So in our practice is like 45 offices. So it's only housed at like 7 offices. And so if you want it, you have to go to one of those offices, right? So you might have to drive a little bit to get it. My concern with these sort of policy changes and these sort of gray area nuanced recommendations is that if we start seeing, and again, this is all what if, right? I can't say this, but if we start seeing low uptake of the Hep B vaccine in hospitals, they may stop carrying the Hep B vaccine in hospitals and say, hey, go to your pediatrician's office and get it there. And then what happens to those families who fall through the cracks? What I mentioned earlier, those lower socioeconomic parents who don't come to me until the 6-month visit because there's not connection. We don't have universal healthcare where you're born and you enter a healthcare system. These patients fall through the cracks so regularly. And in a state like Florida, where there's such a dichotomy between the haves and the have-nots, we don't have a solid middle class here. You're either wealthy or you're poor. I mean, I'm not sugarcoating this in Florida. So we are going to see where the wealthy people are going to get their access. If they want a vaccine, they're going to be able to pay for it. But my big concern is largely that Medicaid population or those who don't have access, that if it becomes low uptake, where are we going to have these vaccines? Is it going to be an affordable situation where these hospitals can carry? And then that may hit your rural hospitals more. That may hit the hospitals with, the budget unable, leading them to go to the pediatrician's office. And I have no doubt that my pediatric practice will continue to house these vaccines, especially the Hep B. But a lot of these mom and pop offices, right? If no one's taking them, they expire. And like, you have to give them out. And so I am worried about the uptake. And that has to do with like the language. And I use that COVID example because that's what we're seeing, right? And COVID is one thing, but Hep B is something different for me. I mean, that is something that we have huge long track records, lifelong issues, like it's been on the schedule for decades. And so it is a frustrating piece. And I don't know what's going to happen, but that is where all of us are scared and hesitant, and worried, to be quite frank, on how that's going to play out here.
Thank you. We touched on this a bit before, but I'll just, Dr. Offit, have you reiterate if you don't mind. Jennifer Fernandez asks, how quickly do you think we'll see the effects of the change in the Hep B vaccine recommendations? So on the ground, I guess.
Years. I mean, even if your worst case scenario is babies who are born to mothers who are infected with hepatitis B who don't get a vaccine, there's an 85% chance they'll get infected. if infected, there's a 90% chance they'll go on to develop cirrhosis or liver cancer. But that takes years. So it would be years to see that. That would be the worst case scenario. The other scenario is that there are mothers who either choose to delay the vaccine or don't get the vaccine or don't complete the series because they delayed the first dose. And there again, it's going to be, when will they acquire hepatitis B? If those children acquire hepatitis B at 1 to 5 years of age, they have a 25% chance of going to develop cirrhosis or liver cancer. This is much different than if you're an adult. If you're an adult, you have a tops 5% chance, if you're first infected as an adult, of developing cirrhosis or liver cancer. But the answer is years, I think, for the hepatitis B. Measles obviously is much different. I think, measles is the most contagious human infection. It has a contagiousness index that's much greater than, the flu or SARS-CoV-2 or rotavirus, et cetera. So that you're seeing immediately. It's really pretty remarkable. I mean, if you look at the CDC website today, it'll say there's 1,900 cases of measles in 42 states. That is a vast underestimate of what's really going on. If you talk to people on the ground in Texas and other states, Louisiana, they think there's at least 5,000 cases in this country and maybe more. And that's only going to get worse. And that's what scares me the most. I mean, I lived in Philadelphia in 1991 when we had 1,400 cases of measles and 9 deaths in our city over a 3-month period. Measles should scare people, and it doesn't. And I think that's the problem. I think it's not only that we largely eliminated measles by the year 2000 in this country, we eliminated the memory of measles. Yeah. And I'm not just talking about for parents, for doctors. I had to speak to medical students yesterday, 200 medical students at the University of Pennsylvania. And one of the students asked the key question. He said, I'm scared about these diseases that like measles, that I've never seen before, or Haemophilus influenza B or whatever, that that we're not trained really to see. How do we get that training? And it's a scary time.
I don't want to get that training. Yeah, I don't want, we're very grateful to have obviously this advancements. It's really sad to see that. And, I agree. The measles, as you know, Florida does have cases as well of measles, and our practice had a vaccine policy. What that means is that we have a minimum expectation, and that's not like requiring flu, requiring RSV, requiring COVID, but the routine schedule, MMR, Hep B, all of that, is that we need you to get it by the next visit. So for example, if you're 2 months and you're not getting everything, you at least have to get everything by 4 months. For measles, you got to get it the 1 year. If not, it has to be done by the 15 month. Like very loose recommendations, but still so that we can promote vaccination. We were threatened because of the policies that are happening here with the mandates, that if we keep that policy, we're losing our Medicaid funding. So now our practice had to reverse back, remove the mandate, because otherwise we'd lose Medicaid funding, which serves a large portion of our population. And so that's scary to me. I mean, we are already seeing measles cases, and we saw them a year ago. And like he said, so very contagious. And it's not even, the Hep B, it could take some time. Measles, pertussis. I mean, we're seeing, I think it was in Kentucky that there's 3 babies that died of pertussis. And measles, those transmissible, very transmissible respiratory ones, right? Your measles, pertussis. I have seen HIV meningitis. I don't want to see it again. Chickenpox, like all of these ones that, gosh, explaining like we do, I know you haven't seen them, but that's a good thing we haven't seen them. Let me explain why we do not want to see these things again without stoking so much fear that if you get measles, you're going to die. But hey, there is a risk here. And that risk greatly is not worth it considering how well tolerated this vaccine is. And so again, going back to that benefit risk conversation, but it's concerning given the pool the politics have had on the public health policy here.
But one quick point is I was a resident at Children's Hospital in Pittsburgh between 1977 and 1980. We would do these emergency department rotations, but sort of 12 hours on, 12 hours off. I would routinely do 2 or 3 spinal taps a night because there wasn't a HIV vaccine, wow. Wasn't a pneumococcus vaccine, wasn't a meningococcus vaccine, not conjugate vaccines anyway. So 2 to 3 a night. Residents at Children's Hospital Philadelphia don't know how to do spinal taps. They don't. When someone comes into the hospital, it's usually an interventional radiologist that does it. That's what vaccines have done for us. Which is a good thing.
Incredible.
Yes.
Yeah.
We're coming up very close to the end of our time together, but I would like to pose one last question for everyone. And Dr. Patel, let's start with you. But if I would love to hear everyone's thoughts on, one story, one thing about childhood vaccines that you think journalists are not covering enough right now.
That's a loaded last question. I like it, though. I would say the one story journalists are not covering enough, and I want to do what we've done. I'm going to say what we've done over time and the actual impact. that vaccines have had in public health, not only in terms of the health itself, but also in terms of healthcare dollars over the past 20 to 30 years to kind of address almost like a counterpoint to what we've looked at when people say we didn't take many shots in the 60s. I would like there to be more emphasis on kind of what Dr. Offit's point was, that we have eliminated these diseases to the point where people don't even fear them, and kind of celebrating what vaccines have accomplished as opposed to constantly looking at this one point in time today. And I'm going to add a second one for bonus. Just please, every journalist, remind people that comparing countries, it's not apples to oranges. Denmark is not the United States. They had 60,000 births. We had 3.6 million. They have universal health care. They have maternity screening. They have close follow-up. They have a low hepatitis B prevalence rate. Please always debunk that point when we hear it.
Thank you. Dr. Offit.
Okay, this is a weird one, but actually it was a gesture that Dr. Patel made earlier. He'll see this here. What you hear from the current administration, RFK Jr. and others, is that they always talk about big pharma, big food, right? And they're above that. They're better than that. They're going to make this better. So, but there is a grift to the anti-vaccine and MAHA movement. There is, and there's this sort of wellness alt-med grift. Look at the money. Look at where the money is. That's what I say. I mean, and they generally don't take that on. Love to see that.
Follow the money. Dr. Amin.
Yeah, mine actually was, I guess, kind of related to what Dr. Patel said about the impact this happens on a system. You know, like what this means in terms of school systems, right? Like we don't think about if you remove mandates, what does that mean for now a kid getting sick and now they have to be out, the parent has to take time off. Like we don't realize that this is economically a disadvantage to remove these things. And I think we think in silos of like, okay, well, I'm just going to appease this crowd. So I would love to see how it can impact education systems, how it impacts the healthcare system, and obviously parents, you know, like their ability to take time off and all of that, and parents leaving the workforce if their kid gets exposed to measles. They can't go, they're going to have to stay home because there's an exposure, I would hope. And then the other big thing is, I think, you know, I talk about this a lot of like, I don't know if this is going to hit for the anti-vaxxers, but why we do vaccines, not only for us, but for other people. You know, I think a lot about my patients who are immunocompromised. I think about a patient who had chickenpox when I was in residency, and he died from his chickenpox and not from his cancer, right? He got disseminated chickenpox. So like understanding that although these things are rare, we're trying to protect the rarities. And when we have something so good that protects the rarity, I think it's great. There was an 8-year-old who died from the flu recently, and I can't remember what state. He was this adorable, cute little black boy. And I was reading the comments in the post, and they were like, it's one child. You know, there was probably something else. I'm like, we see healthy children die from the flu. And I mean, this is not made up. Is every healthy child who gets the flu going to die? No, but we want to share these stories because we know that there is an alternative, so no family has to struggle with this. So if we're going to be hitting anything, like I do like the storytelling, I do like that, but not in a fearful way that if you get this, you're going to die. But we know that there's an alternative. The flu, although not 100% the vaccine, it's going to reduce your risk. It's going to, you know, keep you hopefully out of the hospital. So really bringing in more of those nuanced, what is this vaccine doing versus it's 100% safe, you're not going to have any side effects. It's going to reduce your risk. Here is a link to the most recent study that has shown that. And, you know, a video by Dr. Patel, Dr. Amin, who's talked about that, because that is what I think really hits home, is that any child loss is a child loss. And I hate that sort of narrative that, well, yeah, people die. I'm like, yes, but if we have an alternative, let's use it. Like, let's reduce those risks of death. You know, I want people to have that in their arsenal.
Lauren, the final word goes to you.
Well, definitely don't want to give away any story ideas I might have, but just talking about like broad, no, but talking about just like broad threads that I think about when I tackle these stories that I think is good for any journalist to keep in mind is, and this kind of hits on some of the things that everyone's talked about, the difference between individual health choices and population level health. I think there's just a very broad lack of understanding of the differences between the two, but also the interplay. Mandates. Federal government generally does not set mandates. That is at the state level. No matter what they say at ACIP, they're not setting mandates. So, you know, kind of pre-bunking and debunking some of the suggestions that are made in those kind of contexts, I think can be very helpful. And also to like add on to the systems approach, something that didn't come up here, but came up during the last ACIP meeting was the vaccine injury compensation program. It's tied into all of this stuff. It is another part of the system that ensures that our current vaccination system operates. So that's another like systemic piece of this that is important to keep in mind that could have after effects depending on how changes are made to the schedule in the future.
Thank you. I want to thank all of our panelists, Dr. Offit, Dr. Amin, Dr. Patel, and Lauren Gardner, for providing clarity and certainly some lively discussion today for all of the journalists and others tuning in. I'd like to thank all of the participants who submitted questions, and I'd like to thank our webinar sponsor, Vaccinate Your Children. We will be sharing a recording of this as well as resources after the session wraps. So anyone who wants to watch a replay or send it to someone, you will be able to do so. And for folks who tuned in, you may also be interested on Tuesday. We'll have another webinar on respiratory antivirals. And as any good journalist knows, flu, COVID, RSV treatment searches are all going to be spiking after the holidays. So tune in there and stay up to date on your coverage. And you can also, as my colleague has posted in the chat, you can stay up to date on all of our future offerings by subscribing to our newsletter. So thank you everyone once again for spending this hour with us and for the work that you do. So take care everyone and please stay healthy.
Yes, thank you.
Thank you all.